Habari, my name is Arthur Mathiko, and today I'm at Sali International Hospital here in Dar es Salaam, Tanzania. The topic is general medicine and cardiology, and our guest is none other than Dr. Mohammed.
My name is Dr. Hani Mehboob Mohammed. I'm a medical specialist at Sali International Hospital, and I'm also a consultant cardiologist. And also at the moment at Sali International Hospital as a medical superintendent.
Dr. Mohammed, we are here to discuss importantly internal medicine and cardiology, because that's where you are specialized. When someone talks of internal medicine, what do we mean?
Internal medicine, it is a branch of medicine that is dealing with diagnosing medical conditions which are usually either complex or that has not been able to be diagnosed correctly, or maybe misdiagnosed. So we come in to try and get a proper diagnosis, whatever is required, investigation, and up till managing the patient.
Okay, so in internal medicine, what are those specific illnesses do you interact with, especially on a daily, the common ones you can highlight and talk about?
Okay, so as I said, internal medicine is very broad. So amongst illnesses that we deal with is, I would say it is multisystemic. Every part of the human body, every system is being dealt by internal medicine. Yes, so it is like we cannot specifically say like how many diseases, because it's as I said, it's diagnosing and trying to analyze and treat patients with complex conditions mainly. Now, of course, internal medicine is divided into subspecialties. Yeah, we have many subspecialties, as I mentioned, because it's multisystemic. So we have neurology, which is dealing with the brain and the spinal cord. We have cardiology, dealing with the heart diseases or heart conditions. We have respiratory medicine that is dealing with the lungs, the pathologies of the lung. We have the GI, the gastrointestinal branch, or in other words, we call them gastroenterologists, who deal with the gastrointestinal conditions. So just like that, we have many other. We have rheumatology dealing with bones. We have hematology dealing with blood conditions. Dermatology dealing with the skin. So it is basically it's
broad.
It's very broad.
Yes,
it's basically everything in medicine.
Okay.
It covers. So we start usually with internal medicine, then you branch out into a subspecialty.
So now we're talking of subspecialty, and it's a general broad thing. Internal medicine.
Internal medicine
is a broad
topic.
But then if we have to go into specifics, especially on the continent and specifically in Tanzania, what are the major diseases that we diagnose when we come to the hospital? Most people who come to hospitals, what are those common diseases that we find?
That's a very nice question. When we talk about common conditions that we face in any hospital in Tanzania or wherever you go within Africa, we normally categorize those conditions into those which are communicable, and those which are non-communicable. So when you talk about non-communicable, I'll start with that one because it is very like in proportion wise, it is high, but then it is usually missed. Yeah, the non-communicable. So when I talk about non-communicable conditions that we normally meet in our continent or in our country or at our hospitals here, mainly we deal with conditions like hypertension. Okay, we deal with conditions like diabetes mellitus. So those are the common that we usually come across. Yeah, the non-communicable, because non-communicable, it means it is not transferable. Like you cannot spread by contact.
Okay.
Or by being next to a person, then you get it. Like
COVID-19.
Yes, but now when we also have communicable conditions. Now the communicable diseases are those which are which are usually the infectious. So the common ones being malaria in our setting, it's very common. Pneumonia or the lower respiratory tract conditions. We have the upper respiratory tract illnesses. We have other conditions which are spread by like as an infectious pathology. Conditions like dengue, we also see it quite often. So I would put like that, like as there are those which are communicable, those which are non-communicable. Yes.
So basically here in Tanzania, we see malaria and respiratory diseases, overriding others. So in malaria, I understand there is a lot of research going on concerning, research keeps evolving.
Yes.
Almost in every field.
Yes.
So tell us what you know about the evolving new researches on malaria. Do we have new drugs? Because we've had the chloroquine, then we got many others in the field. So what's going on, and why is it malaria going away?
So malaria, it has been with us for years and years. And you see, I would, before I go and answer the question, I would try to be more general first. You see, malaria, it's a disease or an infection which is spread by a mosquito bite. So in order to cut down the spread of such a condition, we need to also take preventive measures, which I think in our setup, usually the preventive measures are not followed thoroughly, or they might be overlooked,
or because people lack awareness,
or lack of awareness on the public side, or people don't have enough knowledge. So you end up, like causing the disease to spread when it is something that can be prevented. Now, if you have a patient or any person who comes with a malaria infection, normally we try to address with the standard guidelines that are being put by the country itself. So we have like standard guidelines for treatment guidelines for treating different conditions in our country. So one of it is malaria. So we follow the protocol. So we have antibiotics, which are beneficial against patients with malaria infection. The other supportive measures that we take. Of course, there is also researches which are ongoing about trying to get vaccines, malaria vaccine, but that is still
in the process
of like a mass evaluation, so that if it has shown a benefit, then it can be introduced to the mass for consumption. But those are still under trial.
Okay, now yes. In our setting, especially the third world countries, some people, you feel bad, you feel uncomfortable, get a headache, and go to the pharmacy, buy a Panadol and swallow, and you think you're okay. And then could be because of low income or not knowing what is going on. I need your comment on people who go and buy off-the-counter medicines without a proper diagnosis from the doctor. What do you tell such people?
You see, over-the-counter medications, it is a very big problem in our setup. There are lots of medications which are dispensed from the pharmacies just over the counter. But I feel, it is basically the disadvantages of that is one, if you have a certain symptom, and let's say you go to the pharmacy, I have fever, then you get an antipyretic, something to control the fever, it will subside that fever. But we should always try to see if there is a fever, then definitely there should be a cause to the fever. So we need to address that cause rather than just controlling the symptoms. Just like you have a headache, you take Panadol to control the headache. But people should understand that they should be, you should not be more vigilant in trying and find out like what is causing the current symptom. So sometimes you might be taking Panadol for headache, but it might be underlying malaria, which you have
Or
not,
something
or
else.
something other infection that you have not gone to the hospital to get checked.
Okay.
Yeah. So the over-the-counter medications, one is you might delay diagnosis. So diagnosing your condition. So and by the time you will diagnose it, it might be too late, because you have been trying to suppress the symptoms while the underlying cause was not addressed. So that is one, is delay in diagnosing the condition. The other problem with over-the-counter medication is addiction. Something called
You
addiction.
get addicted to paracetamol.
Yeah, so there are certain medications that we usually require a prescription from a practitioner before you are able to purchase it. For example, the sedatives. Sedatives, I would give an example, maybe Valium, or bromazepam. Those are sedatives which normally they are consumed for people who have lack of sleep, insomnia. Now, if you are just buying it over the counter, not in a proper way, so ultimately you will end up getting dependent and addicted to that medication. So that is another problem with over the counter. The other problem is emergence of drug resistance. I have a cough, I have a fever, I don't go to the hospital, but I assume that I have an infection. So I go to the pharmacy, I get my antibiotic, and then I start using. I complete my 3 days or 5 days, but honestly, you don't know what you have treated.
You just
assumed you have an infection. It might be a bacterial infection or a viral or something else. Now, most of our infections that we see are usually viral, which normally you don't have to put antibiotics, because viral illnesses are self-limiting. So I would, so that is another problem with over-the-counter medication. So emergence of resistance.
Yes. Okay. That brings me now to another point of regulation here in Tanzania. From experience, is over-the-counter medication regulated? Are there laws that prohibit a pharmacist from dispensing drugs without prescription of the doctor?
Laws are there, and I'm sure even the Pharmacy Council has laws regarding selling of over-the-counter medications. Usually a prescription is required, but I would just advise the general public, avoid that practice, and also advise the dispensers, the pharmacists, the pharmacy stores, that try and sell something based on a proper prescription, because regulation starts at our level,
the micro level.
Micro level, and then but laws and regulations are there.
Okay.
So it's something that has to be discouraged.
Okay.
Over the counter.
Because when you talk of drug resistance, there are those infections like STIs. Maybe you can talk about it. Those drug resistant STIs. Is it a common thing here in Tanzania?
Drug resistant STIs, drug resistance is a common thing. Okay, especially if you are using, antibiotics. Especially we get resistance to antibiotics. So you get resistance when you either misuse it, or you are using it without a proper diagnosing what is the underlying condition. So you end up with resistance. I would give example like if you're saying about STIs, we have those resistant sexually transmitted infections. It could be syphilis, it could be gonorrhea. Now, those have specific medications that can be used to treat. You need to diagnose it early. You need to go to the hospital, the doctor diagnoses the symptoms, and the medications are started early. But what happens, the same patient goes straight to the pharmacy.
And because you've seen a discharge
Yes.
from down, and then you're like,
So-
I need to buy this.
Yes, so he goes to the pharmacy or she goes to the pharmacy, gets the medication, but now maybe that medication is not properly dosed. It might not be a correct one. And some sexually transmitted diseases, we treat it with combination of
drugs.
drugs. So sometimes you are given one drug. So by the time you use it, you might find some relief, but it is not like 100%
It's
treated.
temporary.
It's temporary.
Okay.
Yeah. And because you used one medicine, then also the chances of resistance are higher. You see, sexually transmitted illnesses, those are, like, it's not one or two types, there are multiple types. So you might be thinking it is a certain condition, but maybe it is not. It is something different, something else. Yeah, we see lots of fungal infections. Normally, when you go to hospital, they either talk about bacterial infections or viral infections. You will hardly hear somebody talk about a fungal infection, because it is something people don't think about it.
Okay.
But it is there. So fungal infections are also there. So you cannot use the normal antibiotics to treat a fungal infection. You need to use antifungal medications. So this is one of the things also internal medicine does.
Covers.
Yeah, we try and to look at those conditions which are tricky, those which are complex conditions. We deal with it's basically we are trying to streamline the management of the proper management of the patient.
Okay.
So that the illness is.
Now we are wrapping up this segment, so I
Yes.
want you to you talked of preventive measures for malaria. I want you to wrap it up. You look into the camera and tell the
Yes.
mama down there, kijijini, mwambie what should she do, to prevent malaria, because treatment is costly.
Yes.
And we've lost lives to malaria.
Okay.
Just wrap it up. Look into that camera and tell
Okay.
that mama what to do to avoid malaria.
Okay. So what I would advise for the general public is, see, malaria is an infection that is preventable. So what we need to do at our level or at the community level is, one, ensure that you don't have stagnant water which is around your household, because that actually enhances or promotes the growth of the vectors who transmit the malaria. That is one. Second is, I would also recommend using insecticide treated nets, the bed nets, which are very important. And of course, in the evening hours, if you are going out or if you are sitting in an open environment, try to wear your clothes which are long sleeved, or long trousers, something that can cover most of the body. The aim being to prevent a mosquito bite. Yeah, but it is something which is highly preventable. So that's what I would suggest. And of course, if prevention does not prevent somebody to get an infection, so whenever you have your family member or any other in the community who has any symptoms which are suggestive of a malaria infection, could be headache, could be body ache, could be nausea, vomiting. The symptoms are very diverse. Yeah. So, but those are the common symptoms. So, try to send that individual quickly, as soon as possible, to a nearby health center or a dispensary or a hospital. Yeah, because you see, early diagnosing the condition is actually going to improve the treatment outcome. Delaying sending to the hospital, then there is a risk of getting multi-organ dysfunction, and maybe even death can occur. And maybe another thing is regarding the pregnant ladies. I would advise also pregnant ladies, whenever they are going for their antenatal clinic, they should actually make sure they are getting the malaria prophylaxis from their obstetricians, because this is very important to prevent malaria in pregnancy. So that is also something that we need to make sure it happens.
Yeah, thank you so much, Dr. Mohammed,
thank
for this elaborate discussion about internal medicine and specifically on malaria, of the counter drugs and infections. Thank you so much.
Thank you so much.
Well, that was Dr. Mohammed on internal medicine, specifically malaria, and off-the-counter drugs. We focus on infections. As I said in the beginning, that we shall also look into cardiology. So don't go away, because we are coming back to discuss issues of the heart. Dr. Mohammed, welcome back for this segment. We are going to talk about cardiology. Why should someone be bothered, to go for such services?
Okay. Yeah, thank you so much. Cardiology, by definition, it is a branch of medicine that deals with disease heart, or the conditions that are related to the heart. And we know heart is the only organ that keeps beating.
Oh,
Yeah, since the time one is born.
until
So
the
it
end.
depends on your lifespan, but it beats throughout
Even when
your
other
life.
organs have
Even
kind
when
of
you are
stopped.
asleep, when you are like it is beating.
Okay.
Yes. So when you say conditions of the heart, uh, conditions of the heart, we put it under what we call as into, again, there are two groups. There are those which are non-communicable, those which are communicable. But before I go into what are the different conditions of the heart, I would like to touch something on what are the risk factors. Okay, because I think people need to know what are the risk factors. That's when they will understand what is the importance of
visiting a
of
cardiologist.
visiting a cardiologist or a physician or any medical doctor to get there. So when I break down the risk factors, okay, there are those risk factors which we call as they are modifiable, and there are those risk factors which are not modifiable. So when I say risk factors which are not modifiable, for example, the age. Age we cannot modify.
Oh, yeah.
If you are 50, you are 50.
You're 50.
We can't go back
Or you
and
can't
make
move
you
ahead.
move ahead. It is a fix. It is non-modifiable. But age, it guides us in a way that if you ask the patient, do you have a family history of a cardiac condition or a sudden death or a heart attack in the family, they will tell you some information. For example, my father had got an attack at the age of 40, or maybe my uncle got at a certain age. So the age will tell us, okay, that condition occurred at a young age in the father, for example. So it means the child is at a higher risk compared to somebody who has got at the age of 70. The one who is getting at the age of 40, the children the risk is much higher. Yeah, but that is one factor which is not modifiable. Okay, but what we advise to these people, you go get yourself checked, because if it happened at an early age, it might recur at an early age. So that is one. The other factor that is not modifiable is the sex. Okay.
You are a man,
yeah,
you are a
assuming
woman.
that there is only male and female. Yeah, you can't. So that is also the risk of getting a cardiac condition in a male is usually higher than a female, unless if the female is in the post-menopausal, then the risks. Because the other non-modifiable risk factor is the genetics. Okay, so if you have a family history of of cardiac condition that is running in the family. So it can genetically come to you, but that cannot be modifiable or modified. It's non-modifiable. So those are, when you talk about the non-modifiable risk factors: the age, the sex, the genetics. Of course, some people also say the race.
Okay.
Yeah. Like if I'm an Indian, I'm an Indian. If I'm an African, I'm an African. I'm a Caucasian. So those also play a role in what risk of cardiac conditions you are going to have, or you might likely to get. Now, when I come into the other part, which is the modifiable risk factors. Modifiable, it means you can modify it.
You can change it.
You can try and change. For example, your eating habits. So eating. Yes, yeah. You see, what you eat is what determines your risk. Okay.
Or your non risk.
Yes.
Okay.
Yeah. So those are the risks. So, like for example, your lifestyle, your eating habits. Are you into a well-balanced diet, or are you somebody who just eats junk food, which is high in fats, too much carbohydrates, you don't balance your food. So that poses many risks. Yeah, not only cardiac conditions, even diabetes mellitus and so many other conditions. The other modifiable risk factor is smoking.
Okay.
Smoking is something that we can control. We can try and quit. So that is something that can be modified, because smoking is a very important risk factor in many conditions, also related to the heart. Okay, it's related to something called atherosclerosis. I think you must have heard about that.
Yeah.
Atherosclerosis. The other modifiable risk factors are your physical activity. There are people who have a very sedentary lifestyle. They just sit, or from office to home, home to office is via car.
To the car.
No
then
walking.
To the bed.
Yes, no walking, no exercise. So that also increases your risk, because you get weight gain, you get other conditions also might come. So that is something modifiable. You can encourage somebody to do exercises, to do walking. Like it's just 30 to 40 minutes in a day walking. Brisk walking is very important. Okay. Yeah, so that is another modifiable.
It's another modifiable
that you can modify it.
Okay, now taking you back,
Yeah.
you mentioned an interesting point.
Yes.
You said issues of the heart, just to make it simple,
Yes.
issues of the heart present more commonly in men than in women. I know it is a non-modifiable factor, but what explains that?
You see, we see more, like we find it more in the male population than the female. Might be because of the access to the hospital also, that the males have easy access to the hospital, or like they have the privilege to go to the hospital to get checked, and compared to the other counterpart. But the other reason might be in the female, the hormones are sometimes protective.
Okay.
Yes, so that is why after the menopause, when the hormones start
to decrease,
yes, so that's when the risks start becoming equal,
to
level, somehow level. And but the risk is there. It's not that the females are not at risk. They are at risk, and the males are also at risk, but it's just the proportion wise is different.
Okay. Yes. Okay, I get it now. At what point should someone go to see a cardiologist? Do I just wake up one day and I say, okay, today I'm going to see a cardiologist? Or do I have to first feel something before seeing a cardiologist? Yeah. Okay. At what point should I see a cardiologist?
Okay, so that's a very nice question. I would like to keep it in two ways. One, there are those who like to do regular checkups. Okay, so it is usually advisable, at least if you don't have any risk factors. Okay, you don't have any other risk factors, like you are not hypertensive, you are not diabetic, or even if you're hypertensive or diabetic, at least once a year you get your heart checked. So that basically tries to like find out if there is any risk of getting a major event that might be life threatening. So it is advisable once in a year to get checked. So there is that population that usually comes for checkups.
Voluntarily.
Voluntarily. Yes. But then, of course, there is another group that comes. Mainly, these are people who get symptoms. For example, somebody wakes up, has a chest pain, or has a breathing issue. Those might not be specific to the heart, or they might be related to the heart. But the only way to find out what is the underlying cause, you need to go and get yourself checked. Yeah, so if you have symptoms, so symptoms of heart conditions, it might be a chest discomfort, it might be breathlessness or shortness of breath. There are activities that you are able to do routinely without any difficulty, but now you can't do those activities because you either easily get tired, or you are short of breath, or you end up with a chest tightness, or the chest becomes heavy. So those are basically alarming, symptoms that
they are pointers that
pointers
there is something wrong somewhere.
Yes, so you need to go and get yourself assessed. It might be cardiac, or it might not be cardiac, but the likelihood for it to be a cardiac condition is very, very high. So that is another group that comes when they have symptoms.
They have some symptoms.
And then there's another group that, those who have high family risk. For example, if a family has somebody who has got a sudden death, okay, or like their siblings, and one of the siblings or maybe two siblings died suddenly at a very young age. So those are called high risk families. Yeah. So we need to closely monitor them. So those are there's another group that normally comes for regular checkups, just to make sure that the condition doesn't affect them also. So broadly, there are three groups. One that just comes for voluntarily, just to get checked. The other ones are coming because they have pointers, so they come. And there's another group which is a high risk, who will have to come, so
because
that
they know it is
the
literally
risk
following
is
them.
yes, the risk is following them, so they need to get themselves checked.
Okay. Talking of checking, get
Yes.
yourself checked. So when you walk into the hospital, in a layman's language, what do you do? What do you check? What do you start with? What equipment do you use?
Okay.
Yeah.
Like how do we approach
Yes,
such
how do you
patients?
diagnose, and then we go into treatment.
Yes. You see, normally it's just the same process. Somebody comes to the hospital. If the patient doesn't have symptoms which are very severe, so they can be seen by the doctor. They can be sent to the doctor's office, check the vital signs, go to the doctor's office. Doctor gets the history, and then plans, after examining the patient, plans what things to do. So depending on what the symptoms are, the doctor might request to do an electrocardiogram, an ECG, or to do some blood markers to see if there is anything wrong with the heart, or maybe any other test that is relevant to try and diagnose what is causing the symptom. The other group is somebody comes and has a very severe presentation, maybe a severe chest pain, or too much shortness of breath. So that patient cannot be taken through a normal process. That patient is immediately sent to the emergency department. So that is where the emergency doctors are going to attend, quickly take the vital signs, and try to get a quick history, and immediately connect the patient to a monitor to see the heart rate or other parameters, and then that's how the approach is going to be.
Okay.
Yes. And the modalities that we use normally to diagnose cardiac condition, as I mentioned, we use ECG, we use which is an electrocardiogram. This is non-invasive. We use echo, which is an echocardiogram, which is also non-invasive. We can also do blood tests. So blood tests, these are tests like if you it depends on what you suspect. Okay. If I'm suspecting a heart attack, then I will order a troponin level, which is a blood marker that is usually elevated in any patient who has a myocardial infarction or a heart attack. Okay, so that marker is usually elevated. Or any other test that we will do so as to identify what is the underlying cause. If I suspect the patient is in heart failure, there are other markers that I will also add. I might request a full blood count. I might even request a sugar level. I might request something called a BNP, which is we normally, that level we check so as to prognosticate the patient. Is the patient having a good prognosis or a poor prognosis? Because that is very important in how we approach. Because in other words, what I'm trying to say, whenever we diagnose a condition, something a doctor always thinks about is the prognosis. Is this patient easily going to come out, or it will take a while, or here it is a very complex issue? So the survival is low or is not good. So that's a poor prognosis. So that is how we see. But those are the two ways that the patients might come to the hospital. Yeah, the two groups that as I mentioned. Yeah.
So in your experience, are those services many people seek, or it's very few people come for it, and what could explain that?
The services, you see, what determines who comes and who doesn't come is just awareness. Okay. We need to make the public more aware. There should awareness on the different conditions. How do they present? Because that ultimately will guide whether they come to the hospital early or they don't come. Yeah, because
they don't know.
Because they don't know. Yeah, so it's just the awareness and to educate them about all these the possible symptoms, signs, and I think the more they are aware, the more they will seek
medication.
To come for the evaluation and and to be diagnosed if there is anything underlying.
Okay, yes. Dr. Mohammed. So as we wrap up,
yes,
we are ending on a good note of awareness. So I want you to look straight into that camera and create that awareness on cardiology services. Straight into that camera. Tell someone why they should bother coming to have their heart checked.
I will just, in brief, just talk about like awareness, as you mentioned. So my advice will be, one, try to see if in your family there is a high risk. Is there any history of sudden death in the family, or a member of your family getting a heart attack at an early age? So that should, in short, or basically drive you so that you should try and seek regular checkups, be it 1 yearly or 2 yearly or like every 2 years. So that is one. So based on the family risk. The other is, as I mentioned earlier, about the modifiable risk factors. So my advice will be One, if somebody is smoking, try and quit smoking. If you are into alcohol, so try to cut down alcohol or even stop. If you have a lifestyle which is very sedentary, I encourage like you should be trying to do exercise, walking, jogging, swimming. Those things can be very beneficial. The lifestyle, what we eat, is very important. Try to eat a balanced diet. So these are the some things that we can do, and also of course there are some things which cannot be modified, as I mentioned. But and the third thing maybe I would add is about the symptoms. You see, there are some symptoms which, if I will mention them, if any of those symptoms at any point they you find you have those symptoms, or any of your family member or any colleague has those symptoms, you try and visit the doctor nearby so that that can be evaluated. For example, somebody with shortness of breath, chest discomfort, leg swelling, uh, as dizziness, excessive sweating, or excessive belching. All those might be or might not be related to the heart, but they can be a warning sign that something is underlying. So if any of those symptoms occur, then I would suggest immediately visit the nearby dispensary, health center, or even a hospital to get yourself evaluated. Thank you.
Thank you so much, Dr.
Yeah.
Mohammed, for that elaborate talk.
Yeah.
And see you next time.
Thank you.
Well, that was it for today. And in case you have questions about internal medicine or cardiology, just get in touch with us as soon as you finish watching this video. Contact me. We shall answer all your questions. Bye for now. See you next time.